Welcome everyone to today's webinar. I am Tracy Cook with Sachs Healthcare Communications, and I'll be your webinar producer for today's webinar on advances in OSA management, treatment of positional sleep apnea. Our moderator today is Steve Coughlin. He is currently the clinical and market access lead for the Night Balance product at Philips Respironics. He has a PhD from the University of Liverpool, which is focused on the cardiovascular and metabolic consequences of OSA. He has over a 15-year career in industry, and he has managed over 100 international industry-led studies and collaborated on numerous investigator-initiated studies. He has published over 10 articles in peer-reviewed journals and presented at numerous national and international medical conferences. Steve, welcome.
Thank you, Tracy, for that very kind introduction. And thank you, Philips, for providing support for this educational activity. The title of today's webinar is Advances in Obstructive Sleep Apnea Management, Treatment of Positional Obstructive Sleep Apnea. We are very fortunate to have an extremely qualified speaker today presenting on this very important and timely topic, Dr. Helene Emsellem. Dr. Emsellem is the director of the Center for Sleep and Wake Disorders in Chevy Chase, Maryland, and a clinical professor of neurology at George Washington University. She is interested in all aspects of sleep disorders, including their diagnosis and treatment, the study of new agents and devices to manage sleep disorders, and public education. Dr. Emsellem is committed to the advancement of sleep medicine and is actively involved in clinical research in many areas of sleep, including narcolepsy and excessive daytime sleepiness, restless leg syndrome, obstructive sleep apnea, circadian rhythm disorders, and insomnia. She has been active with the National Sleep Foundation, promoting sleep health to the public, and is a frequently quoted media source. Dr. Emsellem has disclosed the following. She's been a consultant and participated in the Speakers Bureau for Harmony Bioscience, Philips Respironics, Jazz Pharmaceuticals, and Vanda Pharmaceuticals, as well as receiving research support in addition to the above from the manufacturers listed on the slide. Continuing education is available for physicians. A link to obtain CE credits will be available at the conclusion of the webinar. And this activity is jointly provided by Synaptive and Sachs Healthcare Communications, and support for this educational activity is provided by Philips Respironics. The accreditation statement is located on the slide. For nurses and respiratory therapists, this educational activity is approved for 1 contact hour. And again, the accreditation statement is listed on the slide. So without further ado, I'd like to hand over to Dr. Emsellem to provide her presentation today. Dr. Emsellem, the floor is yours.
Hello, thank you, Steve, and thank you for joining me today in this discussion of advances in OSA management, treatment of positional sleep apnea. Our learning objectives include defining the difference between positional OSA and exclusive positional OSA, or POSA versus EPOSA. We will also differentiate between old forms of positional therapy and newer smart positional devices, and help us all learn to recognize how to screen patients for positional OSA. Positional obstructive sleep apnea, or POSA, is a specific diagnosis, a distinct subset of obstructive sleep apnea. It is a condition in which the patient experiences apneic events when sleeping on their back, and we like to see, in order to meet a definition of positional apnea, twice as much apnea seen while resting on the back or in the supine position as compared to the non-supine position. Guidelines for POSA therapy treatment have been defined dating back to 1984, initially by Rosalind Cartwright, who defined POSA as twice as much apnea on the back as compared to the sides, and has been refined since that time by Markland as well as Medor. Cartwright defined it as apnea occurring twice as much on the back as compared to the sides, and Medor refined this to a definition of twice as much apnea on the back as compared to the sides, and added the criterion of the index on the side being less than 5 events per hour, which is currently considered the exclusive positional sleep apnea definition. The AASM OSA guidelines consider positional sleep apnea to be a second line of therapy or supplemental to primary therapies in the specific appropriate situations. Positional OSA is noted by this exacerbation of apnea in the supine position, and defined by the ASM in 2007 as a 50% reduction in the amount of apnea when one switches from the back to the sides. Exclusive positional apnea is currently considered to occur when there is at least 2 times the amount of apnea on the back as compared to the sides, and when the index, when resting on the sides, is less than 10 events per hour. This is the current working definition of exclusive positional OSA. There is a good deal of clinical evidence about the demographics of the patient with positional OSA, and these articles, interestingly, date all the way back to 1997. The general summary statement about this, and you may want to take your time and pause over this, is that in general, the age is lower in the patient with positional sleep apnea, and there is in more recent studies a predominance of females compared to males by a slight percentage. The other interesting thing on this slide is the prevalence of positional sleep apnea, which is considerable. And other than the Medor study, which looked at only exclusive positional sleep apnea, the general definition of positional OSA encompasses a group of patients that occupy from 53 to 75% of the patients with sleep apnea. So there's a considerable prevalence of POSA out there in the population of patients that we're all seeing. If you look at the definition of apnea and the threshold for apnea, what you can see from this current slide is that the percent of positional apnea drops as the overall apnea plus hypopnea index increases. In translation, the worse the apnea, the less likely it's going to be exclusively positional or positional for that matter. Treatment options for POSA include traditional positive airway pressure devices, CPAP, AutoPAP, BiPAP, mandibular advancement appliances, also termed customized oral appliances, hypoglossal nerve stimulation, surgical procedures to the airway, and body positioning interventions for the subset of OSA that is positional. Weight loss also is a treatment option. We do find in clinical practice that the statistical probability of successfully losing weight is improved if the patient's apnea is treated during the time that one is engaged in the weight loss effort. So treating the apnea and restoring good quality sleep enhances weight loss, and the net amount of weight loss may over time reduce the amount of apnea present. There are limitations to existing positioning devices that are available. Mechanical devices that are strapped on or belted on or attached to the body in some manner may be cumbersome, can cause discomfort, and may disrupt sleep architecture by awakening the patient when you bump into them in an attempt to turn back from the side to the back. Other issues are the fact that there are no clear guidelines published as to the duration of treatment required in order to entrain a consistent side sleep position at night. There's also the question of, with a mechanical device, is continuous treatment required? Is there any time when someone is entrained and one can be sure that they will stay on their sides and not revert to sleeping on their back? Thus, generally, when we use a mechanical device, we are talking about using it for the duration. There are also no clear guidelines as to the interval necessary to restudy to confirm continued efficacy. The point I'd like to make with that is, if you use a mechanical device for your patient and they strap it on and they wear it for 8 weeks and you take them off for 2 weeks and their study is clear of apnea as they're staying on their sides, do you need to restudy them a month later or 3 months later or 6 months later? There are just no clear guidelines as to how to manage the patient with a mechanical device for the long haul. This being a chronic disorder, it is important for us to hopefully get that information. There's also, with the mechanical devices, no objective adherence or efficacy data sent directly to the physician. So just like with a PAP device, when you can read the patient's data card to see how they're doing and how compliant they've been, the mechanical devices don't send that information for the physician directly to review, or their care provider. There is a new therapy to treat positional OSA, which is a sleep position trainer or the night balance device. It's a new technological therapy specifically designed for treatment of POSA. It allows movement while using electronic subconscious stimulus to treat positional OSA. It delivers a variable vibratory stimulus that moves the patient into a non-supine position while the patient continues to sleep, effectively treating the positional apnea by repositioning the patient onto their sides. A critical element of the uniqueness of this technology is that it produces a variable vibratory stimulus so that it doesn't become a learned response that triggers a shift in position without awakening the patient and disturbing sleep architecture. And I'll show you some more information regarding that as we go along here. It also delivers compliance and adherence data directly to the physician. And this is an example of treatment monitoring and the positioning device data that the physician can see. The sample that I have here is 30 days, and the top graph shows the percent of time that the patient was on their back across this time interval, and you can see that progressively decreasing and becoming quite minimal, close to zero, well under 5% of the time over the last 4 days of the 30-day interval. The lower graph shows us compliance. So this is the number of hours of usage, the vertical axis, and this shows usage from night to night over these 30 days. This particular sample also shows the 2 nights very clearly when the patient did not put the device on. There have been several comparative clinical studies, and I'd like to review them with you. The studies that I'm going to review, the first is comparing the use of an auto-adjusting PAP device to the sleep position trainer, SPT or night balance. And the second study is going to discuss comparison between the use of an oral mandibular appliance versus the SPT night balance device. And the third is a study comparing the mechanical or other adjustable positioning devices to the SPT night balance device. And I'm going to take you through these studies. So the first study we're going to look at here is the comparative study of the use of an auto-adjusting PAP device to the SPT night balance device. The study design was a prospective, multi-center, randomized crossover study of the night balance SPT compared to APAP for the treatment of positional apnea. There were 11 U.S. sites, and 117 subjects were randomized, with 110 subjects completing the study. And there was 6 weeks of home use and treatment with both the SPT and the APAP in a randomized crossover fashion. So some patients started with the SPT, some with APAP, and there were PSGs at the onset of treatment with the first treatment intervention, at the end of the first treatment intervention, and at the end of the second treatment intervention, for a total of 12 weeks of treatment, 6 with APAP and 6 with the SPT. The primary endpoints of this study was efficacy, so the AHI from baseline to treatment on the SPT device versus APAP, and adherence after 6 weeks of home use with each, comparing adherence to the SPT versus to APAP. This gives you a little bit of an outline of the study. Basically, subjects were screened for positional sleep apnea, and then received device training and were randomized to a group of 59 subjects who started with APAP and 58 subjects who started with the SPT. After their screening polysomnogram confirming their diagnosis, at the end of each treatment phase, there was 6 weeks of treatment. There was a polysomnogram at the end of the 6 weeks of treatment, and then they switched to the other treatment group. There were a total of 110 subjects who finished the study. 5 subjects withdrew within the first 6 weeks. 3 were voluntary withdrawals. 1 was CPAP. 1 moved to the military who was using SPT, and 1 in the CPAP group was discontinued by the investigator due to non-compliance. In the second 6 weeks of the study, 2 subjects withdrew, both voluntary decisions, and 1 from each group. The results of this study show that the AHI reduction with the night balance was not inferior to the reduction in the AHI with APAP in patients with POSA. Here is the data, and the important things to focus on here. If one looks at the endpoint for the AHI, reading across the first line of the upper graph, the AHI was reduced on average to 7.29 in the night balance group and 3.71 in the PAP group. It's considered non-inferior because the AHI is less than 10. Adherence is interesting in that the adherence in the next row, which was the average usage on all nights, for night balance was 5.8 hours versus 4.8 hours for the PAP device. So there was a slightly better control of the AHI with the night balance, although still the night balance had an AHI under 7.5 events per hour and an hour more usage time with the night balance compared to the PAP device. When one analyzes the primary endpoints for the AHI, this is considered to be a pass in the outcome, and the adherence is also considered a pass. Adherence to treatment, as noted, was significantly better with the night balance, with an average nightly usage by minutes and percentage of nights greater in the night balance group. Patients had fewer arousals with the night balance device compared to the APAP, and the reduction from baseline AHI to treatment AHI was significant for both treatment groups, indicating both devices produced beneficial clinical outcomes. Other outcomes was that sleepiness was similarly improved on both the night balance and the APAP devices, and a greater proportion of POSA patients felt the night balance device was easier to use, easier to adjust, and more comfortable than the PAP device. I'd like to move on now to look at a comparative study comparing a prospective multi-center randomized trial of 99 patients over 12 months, comparing use of an oral mandibular appliance to the SPT night balance device. The oral mandibular appliance in the graph of the apnea plus hypopnea index is in purple, and the SPT device is in green, and we can see the reduction in the AHI over this 12-month period of time in both groups. The primary efficacy endpoint was the change in OSA severity using a composite score of the composite AHI and the oxygen saturation. The results showed that both groups showed a greater than 50% reduction in AHI in about 50% of the patients. There was no significant difference in OSA severity at 3 and 12-month follow-up, thus again showing that the night balance SPT device is not inferior to a mandibular advancement appliance. And the SPT use was associated with a significant decrease in supine sleep time, which was also monitored during this trial. The SPT exhibited higher measures of adherence, including 100% of patients using the device for greater than or equal to 4 hours for 5 days per week. Next, I'd like to review the results of a comparison trial of a traditional tennis ball technique versus the use of the SPT night balance device. The study design was a prospective randomized 1-month trial with an N of 55 subjects comparing night balance to a historical tennis ball technique, meaning that there's a device on the back that one bumps into when one tries to roll over, and that stimulus causes repositioning to the sides. The compliance is noted in the graph to the right over time with the SPT on top and the tennis ball technique below, showing a better compliance with the SPT device. Further definition, the tennis ball technique was a bulky mass ball attached between the shoulder blades to prevent the patient from adopting the supine sleep position. Polysomnography was done at baseline and at study conclusion with validated questionnaires. Daily compliance was measured in both groups. The results show night balance showed improved outcomes with mean disease alleviation significantly improved with the night balance at 70.5% versus the tennis ball technique at 48.6%. And this was quite statistically significant. Compliance in the SPT night balance group was also significantly greater at 76% versus compliance in the tennis ball technique group at 42%. So we've shown you the data that is available from controlled studies looking at the efficacy and use of the SPT night balance device. I'd like to go into a section to discuss how one implements this in practice. For screening patients for whether or not they're a reasonable candidate for positioning therapy, a major question is if the patient is able to comfortably sleep on their sides at night. Do they have shoulder or hip pain that makes it difficult to stay on their sides? If they can't physically stay on their sides, then it's futile to consider a positioning therapy. The other question is if the patient has persistent, loud, disruptive snoring on their sides. So you've done a screening overnight polysomnogram that shows that the patient has either positional or exclusive positional apnea. But you have to also ask about the snoring. If there's a bed partner, they may be still quite unhappy if we position the patient on their sides and there's still loud, disruptive snoring. Snoring alone has long-term health consequences as well. So clarifying whether or not the patient is quiet on their sides is important prior to initiating therapy. Does the patient have significant daytime sleepiness? There's a recent position statement from the Academy of Sleep Medicine suggesting that if there is significant daytime sleepiness present in the setting of obstructive sleep apnea, that the initial treatment of choice in that setting is a PAP device. Does the patient truly meet the definition of POSA or exclusive POSA? And how low, if we're just dealing with POSA, how low is the index when they're on their sides? For example, if the patient has 60 events an hour on their overall, 60 events an hour and 30 an hour on their sides, treating them with a positional device and leaving them with an index of 30 events an hour isn't going to really serve any purpose. So we need to know if they meet the position at the positional sleep apnea definition, and you have to look carefully at those numbers and how much apnea is present when they're on their sides. And can the patient side sleep sufficiently to assess the sleep information. If you have a night where the patient looks like they have exclusive positional apnea, but they were only on their sides for 35 minutes, you may not have an adequate sample. Does the patient have severe comorbidities mandating rapid treatment? I think this is extremely important. If you have someone who has gone into atrial fibrillation that can't be controlled and is morbidly obese and has a blood sugar that's not well controlled, rapid, effective treatment is mandated in that situation, and treatment with a PAP device is usually going to be the more appropriate course to take. So looking at the whole patient and their comorbidities is very important. So best practices when prescribing the night balance positional therapy: review the raw data from the positioning device to confirm, once you've started usage, that there is a decreasing frequency of corrective positioning cues. Make sure that the device is working for your patient and that they're applying it correctly to get the stimulus. Clinical follow-up to confirm resolution of their symptoms. Repeat sleep study to confirm efficacy of treatment and resolution of desaturations. So if you treat a patient with positional sleep apnea with the night balance device, once your graphs show that the patient is not being cued frequently at all and they're using the device nightly, generally recommend a repeat sleep study to confirm efficacy, but also we can't see that desaturation. So if the apnea plus hypopnea index is reduced to 7 events an hour, but when they cycle into REM sleep, they're still having severe desaturations, may not have solved the problem for them. And I think it's always important to encourage weight loss attempts. Weight loss should be most successful in the setting of well-controlled sleep apnea, adequate sleep time, and a regular exercise program. If your patient is successful with weight loss, then reassessment of the baseline degree of apnea present after a period off therapy may be quite appropriate. Let's review some case studies to see how this works. In this picture, you can also see the night balance device strapped to the patient. It's a simple belt with a zipper compartment that the device sits in. Here's our first case. SW is a 49-year-old, 5'9", 185-pound gentleman with a BMI of 27.3. He's mildly overweight. He presents with snoring that is disruptive to his bed partner and daytime tiredness. His Epworth sleepiness score, though, is in the normal range at 4 out of 24, but he rates his sense of tiredness on an analog scale of 0 to 5 as a 3. So this is no overt sleepiness, but rather tiredness. His symptoms have been present for approximately the last 1.5 to 2 years, and he estimates that he's currently getting 6.5 to 7 hours of sleep per night at a typical time of midnight to 7 to 7:30 a.m. So we don't have sleep restriction as a factor here. He has also gained 10 to 15 pounds in the past 2 years. On physical examination, he has an increased neck circumference of 42 centimeters, and looking at his airway, he has a Mallampati class 4 airway with a low-lying soft palate, long, wide uvula, and a large scalloped tongue that has to be compressed in order to visualize the airway. He is also overweight, as we have noted. His past medical history is notable for asthma, allergies, acid reflux, which we frequently see coexistent with obstructive sleep apnea, tinnitus, ADD, and depression. He's had a head injury with a momentary loss of consciousness in the distant past. His family history is notable in that his father has obstructive sleep apnea, hypertension, and heart disease. The social history: the patient is a non-smoker, drinks 1 to 2 caffeinated beverages per day, and 13 to 16 alcoholic beverages per week, but he doesn't drink alcohol at bedtime and doesn't use it as a hypnotic. He's a data engineer and works 40 to 45 hours a week, typically between 8:30 a.m. and 5:30 p.m., and he is exercising at 5 to 7 hours per week. His current medications are Vyvanse or lisdexamfetamine dimesylate, ranitidine, sertraline, and albuterol. He is taking the lisdexamfetamine for his diagnosis of ADD. The history suggests the need for a sleep workup. Factors in his history to highlight this are his disruptive snoring, the daytime tiredness, actually despite the fact that he's on a stimulant for his attentional problems, comorbidities including asthma, allergies, reflux, ADD, depression, and head injury, as there is a slight increase in the risk of apnea in patients who've had a head injury, particularly with loss of consciousness. Body habitus features include the fact that he's overweight with an increased neck circumference and has a Mallampati class 4 airway. And there's a positive family history of apnea. Here is the data from his sleep study. In the top part of the graph, he was asleep at a traditional time consistent with his sleep-wake history and timing of sleep, and the quiet, valid airflow monitoring time, with the time that we had good signal from all parameters without movement artifact, was 423.5 minutes. During this time, he had an overall respiratory event index of 26.8 events per hour. Over the total presumed sleep time of 423.5 minutes, he was on his back 287 minutes with severe apnea during this time and a supine REI of 37 per hour. This is in rather striking contrast to the non-supine REI, over 136.5 minutes of sleep time during which he was on his right side. That's normal at 5.3 per hour. So this meets not only the criteria for POSA, but exclusive POSA. Here's a sample from his study. This is a 10-minute sample with each vertical column accounting for 30 seconds of duration, with absolutely repetitive episodes of complete airway obstruction, with rapid bursts of breaths in between, suggesting gasping with a high gain at times, and associated with oxygen desaturations in the SpO2 channel down to 84%. Also notable is the great degree of heart rate variability, with peaks in heart rate seen frequently with the restitution of airflow following the disordered breathing events. And in the snore channel, you can see clusters of snoring when the patient's breathing. This sample was obtained while he was resting on his back. This is a nice sample for illustrative purposes because it shows when the patient shifts to his side. So over the first 3.5 minutes of this 10-minute portion of the tracing, the patient was still on his back with repeated apneas and desaturations down to 88%. He shifts to his side. There's about 45 seconds of movement artifact, and then he settles down into an extremely regular respiratory effort and airflow signal with stabilization of his oxygen saturations. Also, a dramatic dampening of the variability that was seen prior to this in his heart rate. And there is some very soft continuous snoring versus breathing noise in the snore channel that's seen. This is with a shift from sleeping on his back to on his right side. And this is just a full 30-second sample of the patient settled down on his right side with very regular airflow and barely perceptible snoring versus noisy breathing. This is done with a portable device, so we don't have a true auditory signal to listen to that, but it's a barely perceptible signal. So in this case, the diagnosis with adequate monitoring time and a presumed sleep time of 423 minutes is moderate overall obstructive sleep apnea. He slept on his back 2/3 of the time, and on his back there was severe sleep apnea, and there was a normal non-supine respiratory event index consistent with the diagnosis of exclusive positional obstructive sleep apnea. Let's review another case. This is case 2. RS is a 42-year-old, 6 foot, 286-pound gentleman with a BMI of 38.8. He has a history of a uvulectomy, turbinectomy, and deviated septum repair 3 years ago in an attempt to improve his snoring, and there was transient improvement of the snoring. At this time, though, he has persistent loud disruptive snoring, morning headaches, and reflux that is controlled with medication. His daytime Epworth sleepiness score is abnormal at 14 out of 24, and he's had a new diagnosis of type 2 diabetes over this past year, now is requiring insulin for management and still has an elevated hemoglobin A1C of 8.2. Presently, he's also at his peak life weight at 286 pounds, and he has instituted a diet and exercise program, and his weight just won't budge. Relevant physical exam findings include his significantly increased neck circumference of 46 centimeters, a small chin with 2 to 3 plus retrognathia, and a Malampati grade 4 airway with a huge scalloped tongue, low-lying soft palate, absent uvula that was surgically removed, and a very shallow anterior to posterior airway depth. The history is notable in that his mother, father, and 2 siblings have been diagnosed with sleep apnea, and his mother has type 2 diabetes. The social history, the patient is working a full-time day job, also completing his master's program at night. He is severely sleep restricted with an average sleep duration of 4.5 to 5.5 hours. He had an overnight sleep study in the laboratory, and his total sleep time based on EEG, chin, and eye movement criteria was 482 minutes with a 92% sleep efficiency. Of note in this top left box is a sleep onset latency of just 1 minute. Again, documenting even in a lab environment how sleepy he is. In the respiratory parameter box below this, we can see that the overall respiratory disturbance index, or RDI, was moderately abnormal at 17 per hour. The non-supine index was 10 per hour, and the supine index was 41 events per hour, and that was based on 111 minutes of sleep time on his back. So he does meet the definition of positional obstructive sleep apnea, with more than twice as much apnea on his back compared to his sides, and a non-supine index of 10. He also had moderate snoring, He has oxygen desaturations down to 86%, and there was a total of 7 minutes of sleep time with his saturation less than 88%. So from a diagnostic perspective, he has positional obstructive sleep apnea, but he has significant comorbidities of newly diagnosed poorly controlled diabetes, significant daytime sleepiness with an Epworth sleepiness score of 14 out of 24, obesity with weight stagnation. Treatment. The recommended treatment for this patient, because of the comorbidities, because of the weight stagnation, because of the sleepiness, is CPAP. And we recommended a CPAP titration study to ensure adequate control of the apnea, followed by a clinical trial of CPAP treatment. The fact that we want to stabilize with this patient on CPAP first does not preclude possible future positioning therapy once his medical status is stabilized. Once the patient is successfully losing weight, is getting an adequate amount of sleep because he's severely sleep restricted at this time, and his sleepiness is resolved, reassessment and treatment with a positioning device could be considered. The history of prior airway surgery is not a contraindication for positioning therapy, and that's an important point. This patient did not have a full UPPP, but even a full UPPP procedure is not a contraindication to POSA therapy. We have a third case. PR is a 52-year-old, 5'7", 168-pound woman. The BMI is 26.3, referred for the evaluation of efficacy of her mandibular advancement appliance therapy for obstructive sleep apnea. She had a portable home apnea screening test while using her device. Her prior history was of a diagnosis of moderate to severe overall and very severe positional sleep apnea. As you can see on the graph to the right, her overall respiratory disturbance index was 37. The supine RDI was 63. The non-supine RDI was 35, almost half, but not quite. And the REM RDI was 26 per hour. Initial treatment with CPAP was recommended with mild residual positional sleep apnea on CPAP at 8 centimeters. She had an overall RDI of 5 and a supine RDI of 12 per hour. She had poor long-term compliance with CPAP, and she actually had weight gain while she was on CPAP. Because of these factors, she was referred for an oral mandibular appliance and returned after the appliance was felt to be well adjusted by the dentist who made it for her, who was board certified in dental sleep medicine. She had a portable study at that time, which showed 453.9 or nearly 454 minutes, 7.5 hours of quiet valid airflow monitoring time or presumed sleep time. The respiratory event index was 28 events per hour overall. On her back over 239 minutes, there was an REI of 40 per hour positionally and 14.6 per hour on her sides. So she had persistent apnea, especially positional apnea, with the mandibular appliance, and this is just a sample of the significant breakthrough disordered breathing while the patient was on her back. And this shows a period of time with the patient on her right side with the appliance in, with some residual snoring, but irregular airflow pattern. So this patient has persistent positional obstructive sleep apnea while using her mandibular appliance. She was sent back to the dentist to try to further adjust the appliance as the first course of action to see if further advancement would improve the situation to a better extent. Restudy was suggested once it was readjusted, and if she persists in having apnea, the addition of a positioning therapy to manage the positional component of the apnea, in addition to the use of the mandibular appliance, was recommended. So to summarize, overall, positional obstructive sleep apnea is a very specific diagnosis relative to patients predominantly with mild to moderate obstructive sleep apnea. Positional apnea is defined as a reduction by 50% or greater in the amount of apnea present when moving from the supine to the non-supine position. Exclusive POSA is defined as a supine apnea plus hypopnea index that's more than 2 times the non-supine index, and when the non-supine index is less than 10 events per hour. Message in all of this is screen your patients for positional sleep apnea and for possible candidacy for treatment with a positioning therapy. Treatment with the SPT night balance resulted in non-inferior treatment efficacy and greater adherence when compared to APAP in patients with POSA. The SPT night balance is an effective treatment for POSA and provides the practitioner with monitoring data to ensure that they know that the patient is using the device and that the frequency of stimulation to shift position, reflecting the amount of time the patient is on their back, is being reduced by the treatment. I'd like to thank you for your attention. This does conclude my presentation. I look forward to your questions, and I'd like to turn the mic back over to Steve.
Thank you, Dr. Emsellem, for a very informative presentation and excellent clinical cases. It's really, really good from my perspective to see how these new treatments are being used by experienced doctors in routine clinical practice. We've received numerous questions from the audience. However, before we get to these questions, I would like to tell people how to obtain their CE credits for attending. This session is approved for continuing education for physicians, nurses, and RTs. This educational activity is approved for 1 contact hour. To obtain CE credits, go to saxtesting.com/BO. You will need to register at the site, complete the evaluation, and upon successful completion, you will be able to print your certificate of completion. Support for this educational activity was provided by Philips Respironics. So, thank you to everyone who has submitted a question through the Q&A feature today. And I'm glad to say, Dr. Emsellem, that we have several to keep us busy over the next 10 minutes or so. So let's see if together we can get through them all. Dr. Emsellem, the first question is from Jason. Jason asks whether positional obstructive sleep apnea is really as common as the studies suggest. What's your experience from clinical practice?
In clinical practice, I think that it is actually true. I see the positional apnea and the statistics as being accurate, particularly when I look at my patients now when we're using more portable home apnea screening devices, in that I think we are seeing some patients who aren't as severely ill, and we're seeing more of the mild to moderate patients. We are more likely to see positional apnea in that subset, and I think it's every bit as prevalent as these estimates and studies suggest.
Interesting. Thank you very much, Dr. Emsellem. Okay, let's move on to our second question, which is from Lucy. Lucy asks whether there's a common phenotype for POSA patients versus your standard OSA patient. And I note in the slides, Dr. Emsellem, you pointed to several particular things that might help us identify them. What's your perspective on that?
Well, I mean, I think you have to keep an open mind, and you're going to need data in order to make a diagnosis. But the common phenotype is slightly more females than men. More likely to see this when the overall index is in the mild to moderate range. We're more likely to see that as the degree of apnea gets worse. It becomes more prevalent in all positions. We do see POSA in thin patients, and it's not perhaps, it's perhaps even less BMI dependent than non-positional apnea.
Thank you. So would I be right? This is a question straight from the host. But given the phenotype that you've sort of just alluded to, do you think these are the sort of patients that would traditionally struggle to adhere to CPAP therapy, given that they're younger, maybe slightly leaner, less sleepy, and less severe overall?
Well, I think that's, Steve, a really important point. I mean, convincing a patient who is not having a lot of their own symptoms that they can perceive and feel, particularly the tiredness, it is more difficult, and giving them options is a reasonable thing to do.
Thank you, Dr. Emsellem. We've actually got a question that's been quite consistent across several audience members. So I can't give you a name for this one, but they're asking me if you could reiterate why they should not just use a tennis ball or a positional belt to keep these patients off their back, considering that these options are fairly cheap and easy to get the hands on. I mean, do we really need a more advanced treatment option for these patients with POSA?
Well, from our experience, the use of a mechanical positioning device that's going to be a bulky object on the back is something that most patients just simply don't want to wear for the long haul. They don't want to keep it on. It disturbs sleep. If there's the slightest degree of sleepiness present, we find that the patients aren't compliant because they're more exhausted in the morning and they can't get over that hump of enough usage to entrain the side sleep position. I think over time, those devices can entrain a side sleep position. It's not so much that you shouldn't use it, but is it better to be able to monitor your patient, to know that the time on their back is being reduced, to be able to see that reduction in time, and to be able to say, my patient is compliant with treatment. I mean, one of the major questions that's raised historically about any of these mechanical treatments is you don't have proof positive that the device was used. So there are truly advantages to these more advanced treatment options. It doesn't absolutely preclude the others, but there are problems with the others, and thus the development of this option.
That's an interesting perspective. I have to admit, I've not considered it beyond the lack of long-term use for the mechanical devices. So thank you for that. Question 4 is actually a practical question from Amy. Amy wants to know where active positional therapy with devices such as the night balance device fits into your routine clinical practice, Dr. Emsellem. Is it something you consider a first choice therapy, or is it a second choice therapy that you switch to when CPAP and mandibular advancement devices aren't tolerated or successful? And when you think about this, how do you decide which treatment to apply first and second?
Well, as we illustrated in these cases, I mean, you need data and you have to look at the entire patient. We do in our practice consider positioning therapy as a first-line treatment. We've shifted from using it as a second-line treatment to a first-line treatment in patients particularly with exclusive positional apnea, and when the non-supine index is less than 10 events an hour. I think it is a reasonable first-line treatment. I think what the night balance SPT device provides us with is ongoing monitoring of therapy that gives us a comfort level that we are in fact effectively treating our patient, and that it is unobtrusive enough for patients to be willing to use it on a night-to-night basis. So we do see that it fits into our clinical practice for this selected group of patients, and when they really are positional by these definitions, it can be a first-line therapy. I think it's just really important to emphasize, if you have a very sleepy patient, if you have a very medically ill patient, you're really going to want to use not the positioning device or a mandibular appliance in that situation. You're going to want to go ahead and use a PAP device and get the apnea treated.
Very clear. Thank you, Dr. Emsellem. I'm going to move on to question 5 now. Sam asks a very interesting question. Sam is asking whether you have experience of combining active positional therapy with other OSA treatments. Is that something you've done before, and what do you think about that from a clinical perspective?
Well, I mean, I think there are selective instances where combination therapy is a great idea. I mean, as illustrated in the patient with the mandibular appliance, I mean, we'll see patients come back with an appliance. They really can't tolerate further advancement of their lower jaw, and they're pretty clean on their sides. So adding a positioning device to this is really a reasonable strategy. I mean, you can always offer that they go back to full use of a PAP device as the alternative if there's still persistent apnea. But it's very reasonable to use it in that setting. The other setting is when you're dealing with a very sick apnea patient with high pressures, with a high pressure requirement that's difficult for them to tolerate, and the high end of the pressure is needed to clean up the apnea on their backs. So sometimes you can reduce the overall pressure need and improve the tolerability of the PAP device if you can keep them on their side. So in this very sick subset of our apnea patients, the addition of an SPT positioning device is quite reasonable.
Thank you for sharing that experience with us, Dr. Emsellem. That's very, very interesting. We only have time for one more question, which is going to come from 2 of our audience today, Tess and Jenna, who've both asked us, what patients report back to you about active positional therapy, such as that delivered by the night balance device, compared to CPAP and MAD therapies now, mandibular therapies. Now, I know what you reported from the trial, but in your clinical practice, what's the real-time feedback like?
So, I mean, in clinical practice, patients are very happy with the less they have to put on and be bothered by. people have a series of complaints about CPAP, from just the mechanical issue of having to have it on, having to travel with the device, all the way down to having difficulty tolerating pressure, interface issues, etc. We work hard to resolve those, but they're there. For patients with mandibular appliances, there's sometimes discomfort in the TMJs, the bite. Some patients have difficulty getting their bite back into a comfortable position. And when appropriate, the positioning device can provide them with a very viable option as long as they're a reasonable candidate.
Perfect. Thank you, Dr. Emsellem. I'd like to thank everyone in the audience. Unfortunately, that's all the time we have for questions. And I'd like to also take this opportunity to thank Dr. Emsellem for the most insightful, relevant, and very professional presentation. It's been an absolute pleasure to hear both your point of view and to hear your clinical experience with positional therapy. And it certainly gives me a lot of food for thought for how I approach this segment in the future. At this point, I'd like to turn the presentation back to Tracy for final comments, and I wish you all a very good evening.
Thank you, Steve, and thank you, Dr. Emsellem, for your informative presentation today. We'd also like to thank Philips for their support of this educational activity. On behalf of SACS Healthcare Communications, Philips, and our presenters, thanks for joining us today, and have a great rest of your day.